I'm gonna read nephrotic syndrome from marrow edition 6. Let's start. There is a massive proteinuria of more than 40 mg per meter square per hour in nephrotic syndrome, and urine protein to creatinine ratio is more than 2, done in the first morning sample, that is called as the spot test, and on urine dipstick there is 3 plus or 4 plus. Other features of the nephrotic syndrome will be hypoalbuminemia will be seen with the serum albumin of less than 3 gram per deciliter. There will be generalized edema and hyperlipidemia due to increased lipoprotein synthesis with the serum cholesterol of more than 200 mg per deciliter. So what we saw, there will be massive proteinuria, there will be urine dipstick, 3 plus and 4 plus positive for protein, and urine protein to creatinine ratio more than 2. Serum albumin less than 3 gram per deciliter, generalized edema, hyperlipidemia, and serum cholesterol of more than 200 mg per dl. How we diagnose the nephrotic syndrome? By proteinuria, hypoalbuminemia, or edema. Okay, this is very important. Proteinuria and hypoalbuminemia or edema. Hyperlipidemia is not a part of criteria as per 2021 guidelines. Now the disorders associated with nephrotic syndrome is first is the minimal change disease. Overall, most common condition associated with the nephrotic syndrome in children is the minimal change disease. What happens in minimal change disease is loss or effusion or effacement of the food process of the podocytes, which leads to loss of negative charge, and this leads to loss of protein in the urine, because protein and negative charge repels each other. But if there is and so it is not filtered in the urine. But if there is loss of negative charge, so protein will be filtered in the urine, resulting in proteinuria. Significant change disorder may also be present, which includes focal segmental glomerulosclerosis, membranous nephropathy, and membranoproliferative glomerulonephropathy. These were all the significant change disorder. Let's see the difference between the minimal change disease and the significant change disease. First is the age of onset, which is less in minimal, that is 2 to 6 years, and more in significant, more than 10 years. Gender, minimal change disease more common in males, M for males. And significant change disease is equal in both. Hematuria will be present only in significant change disease. Minimal change disease, it will be absent. Blood pressure will be normal in minimal change disease. May have hypertension in focal segmental glomerulosclerosis. C3 will be normal in minimal change disease, but may be low in the MPGN type 1. Selectivity of the proteinuria, it is high selectivity, and in significant change disease there will be low selectivity. If there are significant changes present, no, so all kinds of protein will pass out from the glomerulus, right? In response to steroids is excellent response seen in the minimal change disease and bad response in significant change disease. Prognosis is always good in minimal change disease, and significant change disease prognosis is variable. Okay, so what were the main differences? Minimal change disease occur in younger population, more in males. No hematuria, normal blood pressure, normal C3, high selectivity to proteinuria, and excellent response to steroids, and prognosis is good. While in significant change disease, because there are different conditions like FSGS, MPGN, and MN, so variable prognosis. Response to steroids is not very good, it is unsatisfactory, and hematuria might be present, and it is seen in more than 10 years of age and equal in both males and females. Now, steroids in minimal change disease. Minimal change disease shows excellent response to steroids, we all know that. When we call remission, a condition where a child responds by reduced protein excretion of less than 4 mg per meter square per day, or urine PCR less than 0.2, or urine dipstick, which is usually done in our hospitals, is urine dipstick, nil or trace for 3 consecutive early morning spot tests. Okay. Treatment schedule. Oral prednisolone is started at the dose of 2 mg per kg or 60 mg per meter square. This meter square dose by body surface area is considered slightly superior. Okay, for 6 weeks. Why so? Let's give you an example. We have a child admitted in May 2025 with nephrotic syndrome, and her weight was 10 kg around then also, and now in 2026 April she has come again her weight is the same, but her height has increased, so her body surface area will also would have been increased, but her kg weight is same. So according to this, we can't give her dose by per kg, right? We have to give by body surface area. We have to increase the dose after 1 year of age. Okay, maximum dose is 60 mg per day. So oral prednisolone in 2 mg per kg and or 60 mg per meter square for 6 weeks. You have to give for more than a month initially, okay, and followed by alternate day oral prednisolone of 1.5 mg per kg per day or 40 mg per meter square again for 6 weeks. So total duration is 12 weeks, which is 3 months of total treatment is given in nephrotic syndrome, and maximum dose in alternate day therapy is 40 mg per day. Typical course of nephrotic syndrome is characterized by relapses, massive proteinuria of more than 40 mg per meter square. What this means was, just hold on a minute, that nephrotic syndrome, now children will relapse like it is almost bound to happen. Relapse is almost bound to happen. So recently why she relapsed was she just had fever and upper respiratory tract infection, and this led to the relapse of nephrotic syndrome. Just a simple cold and cough and fever. She's having urine dipstick of more than 3, right? 3 plus or 4 or for 3 consecutive spot tests. When we call relapse, this is the criteria to diagnose relapse. Massive proteinuria, urine protein creatinine ratio same for more than 2, and urine dipstick 3 plus or 4 plus for 3 consecutive spot tests. Occurs till 2nd decade of life. Relapse will occur till 2nd decade of life. This is very important. Her mother was asking me that will she be fine when she'll grow up? Yes, she will be. Kind of, the relapse will decrease, but relapse will occur till 2nd decade of life. Moving ahead, this is the treatment of relapse. Okay, daily steroids till the child achieved remission. We saw what was remission, that the urine dipstick was negative or nil for 3 consecutive days, followed by alternate day steroids for the next 4 weeks. So remission will usually occurs within 7 to 14 days. Let's see how much time does she take. Congenital nephrotic syndrome, early onset nephrotic syndrome, less than 3 months. Fine, so treatment after remission is for alternate day steroid for next 4 weeks. Let's see what we read till now in nephrotic syndrome is there will be massive proteinuria of more than 40 mg per meter square per hour, urine protein creatinine ratio more than 2, and urine dipstick 3 plus or 4 plus for protein, hyperalbuminemia, generalized edema, hyperlipidemia, serum cholesterol more than 200. To diagnose it, there must be proteinuria and hyperalbuminemia with edema, and hyperlipidemia is not included in the criteria. Minimal change disease and significant change disease. Significant change disease includes FSGS and MNN, membranoproliferative glomerulonephropathy. Steroids we started, right? Treatment schedule includes total 3 months of treatment initially for 6 weeks, 60 mg per meter square or 2 mg per kg, and after the next 6 weeks, alternate day oral prednisolone by 1.5 mg per kg per day or 40 mg per meter square. For 6 weeks. In case of any relapse, which occurs till 2nd decade of life, we have to give daily steroids till the child achieves remission, followed by alternate day steroids. Now let's read about congenital nephrotic syndrome in the next part.